All right, well, now we're getting farther down the alimentary canal into the stomach. All right. So your book chapter is 55, Care of Patients with Stomach Disorders, and the first thing they talk about is gastritis. But I just want to mention before we go to gastritis, probably one of the most common things you hear that has to do with the stomach is nausea and vomiting. And chances are that each and every one of you has experienced at some time at least nausea in your life, if not vomiting as well. So nausea is that feeling of discomfort, and you have a conscious desire to vomit. You don't want to, but there's still that desire, like you would just feel better if you could vomit. So vomiting is the act of throwing up, and emesis or vomit is what the contents that are expelled. But I wanted to mention this because if we really think about what goes on during this process of vomiting, there are so many things going on at the same time that it's so complex. Your body just requires a coordinated effort with all of these different things going on just for one act of vomiting. So what actually has to happen here? Several structures are involved. So the glottis has to close. Deep inspiration and contraction of the diaphragm in the inspiratory position. The pylorus closes. Remember where the pylorus is? The pyloric sphincter. Relaxation of the stomach and lower esophageal sphincter, or the cardiac sphincter. And the contraction of the abdominal muscles with increasing intra-abdominal pressure. So all that occurs just to vomit. So why am I mentioning that? Well, because vomiting many times is part of gastritis. So gastritis, the inflammation of gastric mucosa, so the stomach lining is inflamed. Inflammation can be scattered or localized. So gastritis can be classified by cause, the changes in the cells, or distribution of the lesions. It can be erosive and cause ulcers, or non-erosive. It can be acute gastritis that typically heals after several months, or it can be chronic gastritis, which does not heal after several months. So, literally speaking, gastritis is literally inflammation of the stomach lining. Again, chronic doesn't heal well. The stomach lining thins over time and increases our risk of gastric cancer. The most common chronic gastritis is caused by an H. pylori infection. Symptoms of gastritis include abdominal pain, cramping, bloating, nausea and vomiting, vomiting blood, having blood in the stools, or heartburn. We can diagnose gastritis with an EGD with biopsy to check for cancer or an H. pylori infection. So generally, our stomach is protected in the mucosal layer by prostaglandins. So the prostaglandins actually prevent the stomach from digesting itself. You know, I had talked a little bit before about pancreatitis, where those digestive enzymes actually auto-digest the pancreas. The stomach can do the same thing if there's a break in that mucosal lining, because there are, part of our stomach secretions are also digestive enzymes and hydrochloric acid. So the prostaglandins are actually providing a protective mucosal barrier that prevents the stomach from auto-digesting itself. So if there's a break in that barrier, the mucosa is injured and breakdown can occur. So that's kind of what happens in gastritis. So chronic gastritis appears as patchy, diffuse inflammation of the mucosal lining of the stomach with progressive gastric atrophy. What's atrophy? So that's wasting away. So what happens in chronic gastritis is that those parietal cells that secrete the hydrochloric acid, the parietal cells decrease, or the functioning of them decreases, and that source of intrinsic factor is lost. And if you remember what intrinsic factor does, intrinsic factor is critical for the absorption of vitamin B12. So when body stores of vitamin B12 are depleted, a patient can get what is called pernicious anemia. So if you never knew that our stomach had to do with our red blood cells and anemia, now you know that it does. We need intrinsic factor for vitamin B12 absorption, or we get pernicious anemia. So again, going back to the slide here, why do we get gastritis? H. pylori is the most common cause of bacterium. Long-term NSAID use, and you have to think, what are those NSAIDs? Motrin, aspirin, those are just a couple. It's an autoimmune problem. That's type A gastritis. Atrophic, most often seen in older adults. And then other causes of gastritis are, again, alcohol, radiation, and smoking. Symptoms, as listed here: abdominal pain, cramping, nausea, and vomiting. And I listed some others as well: dark stools, heartburn. Symptoms of acute gastritis could be mild to severe and include epigastric pain, anorexia, cramping, nausea, and vomiting. We need to assess for tenderness and bloating, hematemesis. Hematemesis is blood in the vomit. Melena, which is dark, sticky feces, as evidence of blood in the stool. So that's called melena, M-E-L-E-N-A. Aspirin or NSAID-related gastritis can cause heartburn or dyspepsia. Food poisoning has an abrupt onset with severe nausea and vomiting occurring within 5 hours of eating the contaminated food. Gastric hemorrhage can be the presenting symptom and is life-threatening. A GI bleed, an upper GI bleed, can be a life-threatening emergency. Symptoms of chronic gastritis are nausea and vomiting, upper abdominal discomfort, epigastric pain after a meal, and anorexia. How to prevent gastritis? Limiting alcohol, limiting tobacco, hot spices, caffeine, and chocolate. Another preventative measure would be exercising, which improves peristalsis and helps prevent gastric contents from sitting in the stomach and irritating the stomach lining. And then limiting aspirin and other NSAIDs. Treating gastritis. The acute gastritis is treated symptomatically and supportively. The healing process usually occurs within a few days. Treatment of chronic gastritis varies with the cause, so we have to eliminate the causative agents and avoid toxic substances. Chronic gastritis is associated with an increased risk for gastric cancer because the persistent, there's just persistent inflammation and it goes deep into the mucosal lining and it destroys the gastric glands and makes cellular changes. Medications for gastritis. Again, remember those parietal cells that are destroyed, and they are the source of the intrinsic factor that's critical for absorption of B12. So the person who has chronic gastritis may need B12 for prevention or treatment of pernicious anemia. Another person may need antibiotics if they have an H. pylori infection. We need to avoid drugs that cause irritation. Aspirin, NSAIDs. Another culprit is corticosteroids. And there are several antibiotics that are very hard on our gastric mucosa. Erythromycin and tetracycline being two of them. Limit intake of foods and spices that cause distress, like caffeine, things with high acid content in them, like orange juice, heavily seasoned foods, like strong, hot, spicy foods, bell peppers, onions, and again, avoiding alcohol and tobacco. So medications, I had mentioned some of these in the previous chapter. Pepcid. For GERD, Pepcid was one. So those H2 receptor antagonists to block secretions. There are mucosal barrier fortifiers. I mentioned Carafate before. That was actually in the oral chapter, part of the magic mouthwash. but again, it's a barrier. It provides a barrier. Antacids, Maalox, Mylanta, and then proton pump inhibitors, Protonix, and Prilosec are a couple of examples there. Peptic ulcer disease. This begins on page 1107. So when the mucosal defenses become impaired, remember those prostaglandins, and they no longer protect the epithelium from the effects of acid and pepsin, that results in peptic ulcer disease. So 3 types of ulcers can occur: gastric ulcers, duodenal ulcers, and stress ulcers. Stress ulcers are less common, but remember that we do give patients in the hospital preventative, many times it's Protonix, but it's preventative proton pump inhibitor to prevent stress ulcers in the hospital. So again, many ulcers are caused by H. pylori. We don't really know how H. pylori is transmitted, but some people think it's transmitted from food and water that's been contaminated. But it can also be transmitted from person to person. So there's acute versus chronic peptic ulcers. Acute, there's superficial erosions, minimal inflammation, and they are of short duration. They resolve quickly when the cause is identified and removed. Chronic peptic ulcers get down into the muscular wall with formation of fibrous tissue, and they're of a long duration, hence the term chronic peptic ulcers. Present continuously for many months or intermittently throughout a person's lifetime. So the chronic peptic ulcers are more common than the acute erosions. So just remember for testing purposes that many of the peptic ulcers are caused by an H. pylori infection. And again, this is a response to bacteria. Our neutrophil level might go up. Do you remember what neutrophils are? They are the first responders, white blood cells, first white blood cell type to respond to an infection. Many times they treat H. pylori infections with an antibiotic. Also, for testing purposes, remember what medications and what other substances can cause peptic ulcers. NSAIDs that break down the mucosal barrier and disrupt the mucosal protection. COX inhibitors like Celebrex. Corticosteroids. Caffeine intake. Theophylline stimulates hydrochloric acid production. So remember those different things that promote gastric ulcers. Again, H. pylori, NSAIDs, corticosteroids, caffeine intake, and theophylline stimulate hydrochloric acid production. Gastric ulcers usually develop in the antrum of the stomach near acid-secreting mucosa. There's a break in the mucosal barrier, and acid injures the epithelium. So with gastric ulcers, gastric emptying is often delayed, and that causes regurgitation of contents from the duodenum that worsens the gastric mucosal injury. A decrease in blood flow can also alter that barrier and allow ulcers to occur. Gastric ulcers are generally deep and penetrating and occur near the pyloric sphincter on the lesser curvature of the stomach. Duodenal ulcers occur in the upper portion of the duodenum. They're deep and they're sharply demarcated that penetrate through the mucosa and submucosa into the muscularis. So they go down into the muscular layer of the duodenum. pH levels are low in the duodenum for long periods. Stress ulcers. If a person is NPO, gastritis can lead to stress ulcers. Extensive burns. People who are in the burn unit can get stress ulcers easily. People who have sepsis can get stress ulcers, or those who have increased intracranial pressure can get stress ulcers. So many times these people are in ICU with severe problems and critically ill. Bleeding caused by gastric erosion is the main symptom of acute stress ulcers. So bleeding. The most common complications of peptic ulcer disease are hemorrhage, which is the most serious complication. So hemorrhage occurs more often in patients with gastric ulcers and in older adults. So you'll see that again. Hemorrhage, most serious complication. And what would you look at in the patient's chart if you want to know if they are hemorrhaging? Or if, what are you going to look at? Yes, you can see the, you probably see blood in their stool, blood in their vomit. But you have to look at lab values to know how bad possibly the anemia is. So you want to look at a complete blood count, or CBC, to assess for anemia. Always look at your patient's lab values. If a patient is massively bleeding, they're going to vomit bright red blood, or maybe have coffee ground blood, coffee ground emesis. So blood in the emesis is called hematoemesis. Minimal bleeding may show up in the stool as a dark tarry stool, or again, that terminology is melena, M-E-L-E-N-A. Melena can occur in people with gastric ulcers, but it's more common in those with duodenal ulcers. Gastric acid digestion of the blood results in a granular dark vomit or coffee ground appearance to the emesis. So all of that was hemorrhage. Perforation is another complication of peptic ulcer disease. So this occurs when the ulcer becomes so deep that the entire thickness of the stomach or duodenum is worn away, and then the stomach or duodenal contents can leak into the peritoneal cavity. So then what happens? Then they get sharp pain, sudden sharp pain, mid-epigastric region, spreads over the entire abdomen. The abdomen becomes tender and rigid and board-like. And guess what that is? Peritonitis. So the actress in the sim lab had put a like a folder over her stomach so that if you would assess that, it would be hard. So that's what she was trying to portray, is that her abdomen was tender, rigid, and board-like because she had peritonitis. The patient often assumes a fetal position to decrease the tension on the abdominal muscles, and they're hoping that that pain is going to go away, or at least decrease somewhat. People with peritonitis are severely ill in a matter of hours. They can get septic and have hypovolemic shock. Peristalsis goes away. Paralytic ileus can develop. Peptic ulcer perforation is a surgical emergency and can be life-threatening. So again, that actress, what happened to that actress? She went to surgery. So management of a perforation: replace fluid, blood, electrolytes. Person gets antibiotics, their NPO, get an NG tube possibly, but they're going to surgery. Pyloric obstruction is another complication. Signs and symptoms: vomiting due to stasis, meaning it's just standing still, and gastric dilation. Obstruction occurs at the gastric outlet or pylorus, the pyloric sphincter. It's caused by scarring, edema, inflammation, or a combination of those. Person has lots of vomit. Because they're vomiting so much, they're getting rid of so much acid, they're going to be in an alkalotic state because they've lost all that gastric juice. So they might become metabolically alkalotic. So to get rid of this obstruction, or manage it at least, we're going to have to put an NG tube in to decompress the stomach. So another actress in your sim lab the other day was vomiting. Although she had a small bowel obstruction, it's the same type of thing here with this pyloric obstruction. Vomit. And what happened to that actress? She got an NG tube to decompress her stomach. Next complication on the slide is intractable disease. And again, we're talking about peptic ulcers. Intractable disease can develop from complications of these ulcers. Excessive stressors in a patient's life, or an inability to adhere to long-term therapy, like medication-wise and that sort of thing. So assessment of peptic ulcer disease. What's the patient's history? Do they use alcohol? Do they use tobacco? What kind of diet do they have? Do they eat a lot of tomatoes, acidic food? Do they drink a lot of caffeine? Do they have an enormous amount of daily stressors? Do they have a history of GI problems? Do they have a history of H. pylori? Do they use prescription and over-the-counter medications that are hard on the stomach? Have they had radiation therapy? Have they had gastrointestinal surgery? How do they relieve their pain? What's the duration of their pain? And has it become worse over time? Signs and symptoms of peptic ulcer. Do they have epigastric tenderness? What are their bowel sounds like? They may be increased initially, but they can diminish with the progress of the disorder. Do they have dyspepsia? Dyspepsia, again, is indigestion. Indigestion is a most commonly reported symptom with peptic ulcer disease. Nausea and vomiting generally accompanies pyloric sphincter dysfunction. Lab assessment. Remember, if the person is having some blood loss, check their CBC. Are they anemic? There are 3 tests to test for H. pylori. We can test their blood, we can test their breath, which is called a urea breath test, or we can check their stool, a stool antigen test. Imaging and diagnostic assessment. The most accurate means of diagnosing peptic ulcer disease is to do an EGD, esophagogastroduodenoscopy. There are also nuclear medicine scans that can detect bleeding. During an EGD, which is a major diagnostic test for peptic ulcer disease, they can take specimens for testing and can do a rapid urease test for H. pylori. And that's discussed in your book. Let's see if I can find that. So that is on page 1111. They discuss, it says other diagnostic assessments. It says the major diagnostic test for peptic ulcer disease is esophagogastroduodenoscopy, which is the most accurate means of establishing a diagnosis. Then it talks about how it's direct visualization, but then they talk about the rapid urease test that confirm a quick diagnosis because urease is produced by the bacteria H. pylori in the gastric mucosa. So that's all on page 1111. Okay. Treatment. Interventions for peptic ulcer disease. Testing question. Not a single drug treatment for H. pylori. It's generally a combination. PPI, triple therapy, which includes a PPI plus 2 antibiotics such as Flagyl and tetracycline, or clarithromycin and amoxicillin for 10 to 14 days. And again, all this is in your book. They talk about it on 1111 in the second column. So it's saying, although numerous drugs have been evaluated for the treatment of H. pylori infection, no single agent has been used successfully against the organism. And then it talks about a common drug regimen for H. pylori infection is PPI triple therapy. So it's all there in column 2. So quadruple therapy can also be used, and that's the triple therapy plus like Pepto-Bismol. So a while ago I said something about long-term use of PPIs, and we don't want to use those drugs for a long time because some studies have shown an increase in fractures with PPI. And if you're talking about like combining drugs, Plavix is a antiplatelet, anticoagulant type medication. So if PPIs are used with Plavix, it decreases the effects of Plavix. So we have to be really careful about that, depending on what type of problems the person has. You know, if they have a history of blood clots and they're on Plavix for that reason, we probably shouldn't be giving them long-term PPIs. Then there are the histamine receptor antagonists, and I mentioned Pepcid or omeprazole, and to take that at bedtime, but there are a lot of facilities that don't. They do not give that at bedtime. Antacids, buffer gastric acid, prevent the formation of Pepcid. They're usually not used alone as a drug therapy. Liquid suspensions like Mylanta and Maalox are used most often, and they're most therapeutic. Antacids should be taken 2 hours after meals to reduce the hydrogen ion load in the duodenum. Tums is a good antacid. But again, we have to watch antacid interaction with other drugs. I mentioned Carafate, and again, that's a mucosal barrier fortifier, so it protects and provides a barrier. Pepto-Bismol inhibits H. pylori from binding to the mucosal lining. So just remember, if you don't know, that Pepto-Bismol has salicylate, and so you should not have a person taking aspirin and Pepto-Bismol at the same time. Pepto-Bismol can cause stools to be discolored and black, and it can also cause the tongue to turn black after prolonged use. Nutrition therapy. A bland diet can help symptoms. Try to avoid substances that increase gastric acid secretion like caffeine and coffee. Avoid bedtime snacks. Avoid alcohol and tobacco. Other therapies that might be used for peptic ulcer disease are ways to reduce stress like yoga and meditation. Some herbs can help. Licorice, zinc, vitamin C, essential fatty acids, vitamin A, all are other therapies that might help with the treatment of peptic ulcer disease. Just remember peptic ulcer disease and perforation. Perforation especially is a medical emergency. It's life-threatening. And blood loss from peptic ulcer disease results in high morbidity and mortality. So again, life-threatening. Upper GI bleeding. Mild bleeding, less than 500 mils. The person might have feelings of weakness and have perspiration. If the blood loss exceeds a liter in 24 hours, they may become shocky, have chills, hypotension, palpitations, diaphoresis, weak, thready pulse. So they're getting manifestations of hypovolemic shock there. So how do we manage hypovolemia? Volume replacement. So isotonic solutions should be started immediately. So what are isotonic solutions? Normal saline and lactated ringers are two of the main ones that we use. The person may be prescribed blood products. Again, look at that CBC. Look at the lab values. That's how a doctor determines if they're going to get blood or not. If there's an active bleed, we may give fresh frozen plasma. And you have to think, what is fresh frozen plasma? What's in there? We have a lot of plasma proteins and blood clotting factors. So fresh frozen plasma, if the prothrombin time is 1.5 times greater than the mid-range value. So we could put an NG tube in, and why would we do that? We would put an NG tube in to see if there is any blood in the stomach. Assess how fast are they bleeding. We want to prevent gastric dilation and administer lavage. So what does that mean? Administer lavage. So if we put an NG tube down somebody who has an active upper GI bleed, we are basically putting fluid down and pulling it back out. We're lavaging, we're cleaning it, we're cleansing it. That's what that means. Gastric lavage requires insertion of a large bore nasogastric tube with installation of room temperature solution in volumes of 200 to 300 cc's. The solution and blood is repeatedly drawn out manually until returns are clear or light pink and without clots. The patient lies on their left side during that procedure. The NG tube may be removed or left in after the procedure is completed. Sometimes that takes a long time to lavage because you're constantly putting fluid in and you're pulling it back out. If an EGD is done, they can inject chemicals into the bleeding site. They can treat it with heat or electrocautery. They can band or clip an area. When I worked in the operating room, part of my assignment some days was in the GI lab. So I saw them put clips in, and also epinephrine. We'd use epinephrine sometimes to inject into bleeding sites because that is a vasoconstrictor and it gets a place to stop bleeding. Interventional radiologic procedures. Arteriogram can be performed to identify the anatomy of the arteries to find the exact location of bleeding. And then a physician can inject a medication into that area to stop the bleeding. And again, we're talking about the stomach. They're just using an approach through the femoral vein or femoral artery. Acid suppression is used to prevent rebleeding. Acid suppression agents stabilize a clot by raising the pH of gastric contents. And then there's surgical management. So there's a laparoscopy to remove the chronic ulcer or treat the hemorrhage from perforation. Part of the stomach can be removed, which is called a subtotal gastrectomy. There's also pyloroplasty to open up the pylorus. And then there's a vagotomy, which is cutting the vagus nerve to control the gastric acid secretions. Just remember that if someone has had surgical management and has had part of their stomach removed, they need to be educated to eat smaller meals because they can't eat as big of a volume if they've had part of their stomach removed. I just put this here as a reminder that what a unit of blood that someone donates, like what components we get from that. So just from a single donation, they can use the red blood cells. And if you see what is the use of those, to increase the amount of red blood cells after trauma or surgery or to treat severe anemia. The fresh frozen plasma, which I mentioned, is to correct a deficiency in coag factors or to treat shock due to plasma loss from burns or massive bleeding. Platelets, to treat or prevent bleeding due to low platelet levels and to correct functional platelet problems. And then cryoprecipitate to treat fibrinogen deficiencies. So again, to stop people from bleeding. So I put that up there because that is now very near and dear to my heart. Gastric cancer, stomach cancer. So most stomach cancers are adenocarcinomas. That develop in the mucosal cells that form the innermost lining of the stomach. There's no symptoms in the early stages, so usually the disease is very advanced when it's detected. Gastric cancer spread by direct extension through the gastric wall into the lymphatic system, and the lymphatics, of course, carry the tumor deposits into the lymph nodes and then directly invade other organs. Gastric cancers can spread through the portal vein to the liver, to the lungs and the bones, and that's the most common modality for metastasis or spreading of the cancer. Advanced gastric cancer invades the stomach muscle and beyond. The survival rate is low because the disease is so advanced before people even know it. So as far as prevalence of gastric cancer, it's more common in males than females. And there's a sharp increase in age over 50. Most people are diagnosed between ages 60 and 80. Again, risk factors. H. pylori is the largest risk factor for gastric cancer because it carries a gene associated with it that causes gastric cancer. Pernicious anemia. Remember those parietal cells that are destroyed? Can't make the intrinsic factor, which helps us absorb B12, so we get pernicious anemia. Other risk factors are gastric polyps, atrophic gastritis, and achlorohydria, which is absence of the secretion of hydrochloric acid. So there's not enough acid secretion in patients with the atrophic gastritis. And so since there's not enough acid, there's an alkaline environment, and that allows bacteria, especially H. pylori, to multiply. And so that infection causes the mucosa associated lymph tissue, and it's a lymphoma, which starts in the stomach. So, what are some foods? Pickled foods, nitrates from processed foods, salt, all can lead to atrophic gastritis. Low intake of fruits and vegetables, which are very important for people. It's very important for people to have a well-balanced diet to inhibit H. pylori and gastritis. And then gastric surgery increases the risk because there's a higher risk after gastric surgery for atrophic gastritis. So assessing gastric cancer. What are the patient's preferred foods? What is the patient's diet? Do they like smoked foods or eat a lot of smoked foods? Have they had a past H. pylori infection or a history of gastritis or pernicious anemia? All of those are risk factors. Signs and symptoms. Indigestion and abdominal discomfort, initially relieved by antacids, are the most common symptoms of gastric cancer. So you'll see that again. Let me repeat that. Indigestion and abdominal discomfort that is initially relieved by antacids are the most common symptoms. There's also feelings of fullness. Epigastric or back pain often goes unrecognized. People with advanced gastric cancer have progressive weight loss. You'll see all of that again. Other signs and symptoms: nausea, vomiting, weakness, fatigue, anemia, enlarged lymph nodes. There may be a palpable epigastric mass that would suggest liver involvement. Patient may have abnormal liver function tests. So how do we diagnose gastric cancer? Again, an EGD with a biopsy. And there's also a tumor marker called a CEA. We can use CAT scan, PET scan, or MRI to determine the extent of the disease. So signs and symptoms: abdominal discomfort that has been initially relieved by antacids, feeling of fullness, and progressive weight loss. Okay, interventions for gastric cancer. Again, I'm not going to go through all these because this again is cancer, and you will get that in 435. You can read through all of this in your chapter. Mostly when we discuss treatments for cancer, it's going to be surgical management, surgical resections, chemotherapy, and radiation. That's pretty much the gist of the types of cancers that are discussed in GI for sure. Now what I'm going to do is go through chapter 55. I'm going to go through it page by page so that I did not forget anything that I want to tell you. So just remember H. pylori, chronic gastritis, and pernicious anemia. Key features of gastritis are there on page 1105. It's acute versus chronic gastritis. On page 1106, I just want to point out that under esomeprazole, the Nexium, part of what it's saying in nursing implications is that we need to check for hepatic impairment. A while back I told you that it caused some, there were studies that said that Nexium caused some liver problems. So you need to look again at lab values. And what lab values do you look at? ALT and AST. So you should be looking at all that stuff in clinical as well. Page 1108. Again, what is melena? What is coffee ground? What does that mean? Coffee ground appearance. What are stress ulcers? What's hematemesis? Page 1109, chart 55-4, upper GI bleeding. There's coffee ground emesis again. So look at that chart. What's peritonitis? Under etiology and genetic risk, you need to know that whole paragraph there. It says on 1109, etiology and genetic risk. I discussed all that, but you still need to read over that so you know what that says. Again, no single drug or agent treats H. pylori, so there are drug regimens. Do not forget the diagnostic assessment for peptic ulcer disease, that is an EGD, and then they do the rapid urease test that can confirm the diagnosis of H. pylori. Pepcid, again, most of these drugs given it in the evening or at bedtime. And I know I have some of these questions also on your final on 1116. Look at chart 55-6 for early gastric cancer versus advanced gastric cancer symptoms. And then I have something else there about dumping syndrome on page 1118. Dumping syndrome is managed by nutrition changes that include decreasing the amount of food taken at one time and eliminating liquids ingested with meals. In collaboration with the dietitian, teach the patient to eat a high protein, high fat, low to moderate carbohydrate diet. But again, get rid of those fluids at meals and have them take fluids between meals instead, so it doesn't fill up their stomach so much. All right, so that is stomach chapter. So again, if you have any questions about any of these oral, esophagus, or stomach problems, please do not hesitate to send me an email or text me. I would be happy to answer any of your questions. Thank you so much.